Hello, class. Thanks for joining. This is your exam 3 review. The exam will be similar to your exams 1 and 2. This one will be a little shorter because we have less material, about I think 33 questions, multiple choice and true false, and it will cover all material since exam 2. So first, global partnership. There's a chapter on this, so you should review that along with the slides. And you will remember that a big portion of our lecture for this material focused on the case study, which was the TED Talk video. So I will ask questions about this, and you should be familiar with these 3 recommendations by Dr. Adams to ensure that our global health partnerships are equitable. So you should understand and have examples of what it means to deconstruct and decolonize our global health partnerships. So some examples from her TED Talk included the fact that language is never neutral, and this idea of first do no good. So those are some things to think about and reflect on. Understanding context, the historical legacies, these inequities that are apparent from social and economic standpoint, and how that affects our relationships with global health partners, particularly when we are spanning sort of a high to low income range between the 2 partners. So the US, for example, working in a low resource setting. She also talks about rejecting single stories and stereotypes, and how that can do harm in our partnerships, which relates to number 2. And finally, practicing reciprocity. And this really comes down to making sure our partnerships have equal opportunities that go both ways and shouldn't just go one way. So this is really the prime example is in student exchange programs, where we put a large burden on our hosts of students that could have little yield or little benefit to them, but a great benefit to us, and that those opportunities are not often mutual. So we might send US medical students to Africa to work, and they might even get to do more than they would be legally allowed to do here. But we don't give that same opportunity the other way. So we really need to critically think about who's benefiting from these partnerships. Is harm or are there negative consequences to our partners in these partnerships, and how can we adjust them so that they're equitable? So you should also relatedly know about voluntourism. I gave examples from my own work. This relates quite a bit to the TED Talk that I was just summarizing. So know what voluntourism is, and know some of these sort of negative sides of it. So it's very similar to those 3 principles we were just talking about. So in this chapter, the book covers quite a bit on key actors and organizations in global health. This is in your chapter, it's in your slides, but we focused our time in class on the case study, so it was not, covered verbally, and that was intentional because this has been covered throughout the course. That being said, you should still review the unique material in the slides and in the chapter, because the exam will cover that. So I've taken a few examples that you should know, but like I said, focusing on our slides and then using the book as supplement to understand these different organizations is going to benefit you. So UNICEF is one of the UN agencies, and its biggest function is basically protecting the rights of the child. And when this comes to global health, it's about health and well-being. They're headquartered in New York City, but they work globally. And They do quite a bit around child immunization, maternal and child health, diarrheal disease and pneumonia. And we've also seen that they contribute to the relief of in humanitarian crises, particularly around protecting children and child nutrition. UNAIDS is another agency of the United Nations, and this is the agency that is solely focused on HIV. It's based in Geneva, Switzerland. So they do a lot with providing assistance to individual countries to create national HIV strategic plans, strengthen the country's HIV surveillance, as well as their health systems. So they emphasize prevention, and they work to increase the number of people on treatment by providing technical support and expertise. The Wellcome Trust is a biomedical research organization, and they conduct research either at independent institutions or institutions that the organization itself creates, and their focus is on improving facilities specifically in low-income countries. And then you should know which organizations are the major funders of global health research. So in the United States, the National Institutes of Health, or the NIH, which I think a lot of people know about now because that was brought into the public light with Dr. Fauci contributing quite a bit to the COVID control, but he is from the NIH, that they fund a huge amount of global health research, not just to US-based institutions, but to global institutions. My research personally is funded through the NIH. And then there's similar agencies in other countries like Australia, the UK, etc., that are supported by their national governments. But in addition to those federal agencies, there's the Gates Foundation. The Bill and Melinda Gates Foundation does a huge amount of global health. The Wellcome Trust we just talked about, and the Howard Hughes Medical Research Institute do quite a bit when it comes to funding research. So moving on to non-communicable diseases, which also covered mental health disorders just sort of lightly in the book chapter. Some key terms, I think it's important to know what cardiovascular disease is, or CVD, that it encompasses both ischemic heart disease and stroke, and it is a disease of the heart and blood vessels. It's also important to know that this is the largest contributor to basically mortality globally, and this is irrespective of gender, as well as irrespective of country income. I think that's basically what is presented here, that these two together represent CVD, which is the ischemic heart disease and stroke, and it's making up 27% of global deaths. And then heart disease also causes, as I said, sort of the leading specific cause of death for all ages and both sexes. Important to know the risk factors and the fact that these are modifiable versus non-modifiable, that these risk factors are lifestyle factors for the most part when it comes to the modifiable risk factors, and they are shared across many of the NCDs that are the leading cause of death and disability globally. You should know diabetes by region. What are the regions most and least affected? As you can see from this graph, North America and the Caribbean are the most affected region in the world. This is basically showing us diabetes by region. Once again, although, let me see the difference here. in the West Pacific there, which is not listed on the, oh, it is listed here. So this is diabetes by region, but I believe this is actually death due to diabetes. Sorry for not clarifying that. And then it also is showing the projections of growth over the years. But I think, yeah, it's important to know that this is about deaths, which you see is higher in lower income settings like the Western Pacific, South Asia, whereas the prevalence is still highest in North America and the Caribbean, followed by the Middle East and Africa, and North Africa, excuse me. So we learned in this lecture that tobacco use is, of course, one of the leading risk factors for non-communicable diseases. It contributes to stroke, heart disease, cancer, and basically COPD, basically all of the NCDs that we have covered. And so it is the single most important investment that any country can take to reducing the burden of NCDs. So very important prevention efforts should really center on reducing tobacco use. Alcohol consumption by region, this is basically showing highest versus lowest. So I recommend you study this and have an understanding based on this graph of what regions are most and least affected. Least affected being this light color. You see that this is North Africa and the Middle East, and most affected being this dark color. And we see that mostly this is Europe. Again, alcohol consumption per person on a global scale. It's also important to have an understanding of how we can best prevent or reduce the burden of alcohol-related injury and illness globally. And this really centers on policy level change that would limit access to alcohol. This would have the widest impact on the outcomes, the negative outcomes related to alcohol. So taxing is an example of that, limiting the hours where alcohol can be sold or bought, checking like sobriety checks and things like that. So this is sort of, I think, the opposite of the individual level. We can, of course, do education with people about the harms of alcohol. We can do education with healthcare providers or have them provide counseling to people. But that's not going to have as big of an effect as policy level change. That's going to have societal level influence on how many people consume alcohol. Okay, so we're moving on to natural disasters and humanitarian crises. We have a chapter and a lecture on this. You should know the difference and the definitions of a refugee, which is a person who's outside of their country of residence and has sought refuge because of a fear of persecution due to their personal identity, because of usually some type of conflict happening at their nation of residence. Whereas an internally displaced person is someone who's been forced to flee where they live, but they're still within their own country. And this is a result of a disaster or a complex humanitarian emergency. The health burden of natural disasters, you should really understand sort of the direct and indirect impacts of natural disasters on health. So, of course, in a direct sense, people can die directly of a natural disaster like an earthquake or a hurricane, or be injured, right, directly because of that disaster. But there are, of course, these indirect effects that can be short-term or they can be long-lasting. That can have impacts on health, but also you should, really consider things like the outbreaks of infectious diseases, how it can decimate a health system or the institutions that we have that protect health, and how that has sort of long-term or short-term impacts on maternal and child health, the rate of diarrheal disease and things that are associated with our infrastructure, and things of that nature. So when it comes to addressing health effects of humanitarian emergencies, you should know about what we do in terms of assessment and surveillance of health to ensure that we can provide the best and most needed interventions. So this includes checking the weight and height measurements for children under 5. This is a measure of wasting, right? We want to make sure that we don't see drastic malnutrition as a result of being displaced, which often is the case. So global health agencies like UNICEF do quite a bit to monitor the weight and height measurements of children and other measurements that are indicators of malnutrition. We also assess the daily crude mortality rate. This is a mortality rate just in sort of looking at a very short term mortality, and we're basically monitoring that to see if that's jumping or significantly increasing, and then if it doubles, what is the sort of baseline rate? That is what we would consider a public health emergency. You should understand what humanitarian agencies do to protect the environment of displaced people as well as refugees in complex humanitarian crisis. Of course, clean water, shelter, sanitation facilities are going to be key to making sure people there's not infectious disease outbreaks that are related to wash-related conditions. You should review the slides on the earthquake that happened in Haiti, which we talked about in class as a sort of case example of a natural disaster and its sort of multiple ramifications on health. Of course, a significant number of people died directly as a cause of this earthquake in 2010. But 10 months after the earthquake, there was a devastating and long-lasting cholera outbreak that affected health. And of course, there were other indirect effects, as a significant, I think 60% of all health facilities were destroyed due to this earthquake. So you can imagine that this had really significant impacts on basically all aspects of health. We also talked about in this lecture violence against women and how that increases during humanitarian crises because of a lack of security that happens in conflict settings. But we also talked about how there can be lasting impacts on women's health and violence against women in a post-conflict setting. And we use this case example of Liberia, who had a devastating civil war, but even 10 years and greater since that conflict ended, we still see very high rates of violence against women within relationships, intimate partner relationships. And we do see that people who have experienced trauma or conflict-related violence are more likely to either be a victim or perpetrate violence against an intimate partner, both during and after conflict. And then we saw from this study that even living in a residence where there was conflict fatality was associated with a 50% increased risk of intimate partner violence post-conflict. So you should understand this and understand some of the mechanisms that might explain that. And I shared some of my research with you that showed how mental health, like depression and the long-term effects of trauma, is one pathway. Anxious attachment style being because of the long-term effects of losing parents, being separated from family. This justification of wife beating is basically an indicator of norms that accept violence against women. So because there was so much violence in the conflict and violence against women was used as a tactic of war, it creates norms that basically are more accepting of violence overall. And then not represented in this model, but also important to understand is, of course, just the effects on the community structures. So you won't have as much security, police or legal structures that can support or prevent violence against women in a post-conflict setting. There are a number of key organizations that we talked about that respond to humanitarian crises, such as the International Rescue Committee, and a really large number of UN related or United Nations related agencies, which are pictured here. We've talked about UNICEF already in this lecture, but quite a few that are responding to humanitarian crises in a number of ways. What is this? Talked about this already. This must be out of place. Okay, well, we talked about those, but I think what maybe we didn't say is that NCDs in Senegal was a topic that was covered by Dr. Balou, who gave a guest lecture as our last in-person lecture. I did not include slides on this because I really tried to really ask you to come and attend, and I do have extra credit towards those who did, and I think that those who did will be in a good place to respond to the questions on the exam on this. But I think everyone else should be held responsible to review her slides and her readings on their own. And so I did not go out of my way to cover that, because I think that was a choice people made to not come. So she has slides on non-communicable diseases in Senegal, which includes some examples from her research. So please make sure you review those for the exam. Otherwise, I hope this is helpful. I hope that you enjoyed the class, of course. Really enjoyed teaching everyone, and I wish everyone the best of luck in not just this exam, but finishing their degrees. And I know that I'm always a resource for you. You have my email, so please reach out if I can ever support any of you. Thanks.